Next, I welcome Dr. Nadhna Basheer, cornea and phaco-refractive surgeon, Arya Eye Care Hospital, Thrissur. Dr. Nadhna will be talking on when the cornea is under attack, keratitis and corneal ulcers.
I am very happy to see so many of us, so many of you attending this session. So red eye is always a very common condition which comes to our OPD. Often corneal conditions like corneal ulcer and keratitis are easy to diagnose because the patient will be already in a state of photophobia and pain. So we'll go to the topic directly. So the cornea is the outermost layer where it is very prone to the external insults and injury, and it's densely innervated. So even a small injury can cause a lot of distress to the patient. Red eye often, due to corneal pathologies, may be overlooked and sent back. So careful examination is always prudent. Coming to the global burden, around the prevalence rate we have found us around 113 per 100,000 population in the South India. And in our population, it is more of bacterial and fungal. And the high incomes countries like the developed countries, the range of infective keratitis is much lesser than our part of the world. Coming to etiology, it can be both infective and non-infective. I'll be mainly dealing with the infective pathology. So these are the risk factors for developing a corneal injury or a topical medication which is injudiciously used, like a topical steroid, use of contact lenses, unhygienic practices, or often after surgeries following LASIK or penetrating keratoplasty. So we know the features of a bacterial ulcer. So there will be the symptoms will be more, and it will be wet ulcers. It is often with a grayish white or yellowish infiltration. Mobile hypopyon is usually present. In case of a pseudomonas ulcer, we can see surrounding cornea having a ground glass appearance. Coming to each ulcers, which is we can point out as a telltale occurrence. So this is at intrastromal abscess seen in staphylococcal ulcers. This is a ulcer serpens, which is seen in the pneumococcal ulcer, where one part of the ulcer will be progressing when the corresponding other side will be healing. It will have dense AC reaction and a large hypopyon usually. Coming to the gram-negative ulcer, most common is the pseudomonas ulcer. Often we see in patients with contact lens use. The feature of this ulcer is a rapidly progression of the ulcer, and it extends to periphery and deep stromal layers very fast. It can often present as a ring-shaped ulcer. Usually the treatment is fortified to 2.5% of amikacin. And then this is the ulcer which is not very common, but it's a very indolent ulcer. With a minor trauma they present, and with normal medications it won't respond. And it has a characteristic feature which is the pinhead lesions at the periphery and having a wreath-shaped in appearance. So how to identify this, you have to use a ZN staining method, and they are identified as long, slender, branching gram-positive rods. Here also the medications we use is the amikacin. So grading also, it's usually 1, 2, 3 rule. So here the infiltrate size represent the 1, which is if it is up to 1, we can treat it with the monotherapy with the fluoroquinolone. Second is 2 millimeter. 2 stands for 2 millimeter within the visual axis. So in that case, we can consider fortified. Always while considering fortified drops, we should always be aware of the toxicity it can cause. So when you're responding to a normal monotherapy, why to start a fortified antibiotics? Always keep that in mind, because toxicity also can damage cornea and increase the epithelial defect and stromal melting. So common fungus that causes ulceration is the Fusarium aspergillus curvularia. So features are again dry-looking ulcers with feathery margins, yellowish-white infiltration, and immobile hypopyon. Certain cases of fungus like curvularia bipolaris, they produces pigmentation. So I'll just discuss a small case which has come with a stick injury, 67-year-old with no history of any diabetes. She developed a fungal ulcer, So presentation was around, the visual acuity was around 3/60. She was treated with natamycin, voriconazole and itraconazole, and patient improved after 1 month of therapy. This is another case. Here I wanted to highlight the patient had a injury with the insect injury, and the patient was presented to me with a lot of medications already started from elsewhere. So it had an irregular appearance. So we'll often confused fungal for viral. So viral antivirals were also started from the problem with starting all of the medication. Patient will be very less compliant. So what happened is I asked the patient to stop antivirals and asked to continue whatever drugs was given. And actually the patient improved. So it's not that you have to start so many of medications. First, identify if it is improving with the minimal therapy, you can continue with that. So you should always keep in mind that it may be a non-compliant patient. Always ask for the drug history. Next, coming to the microspheroidal keratitis. This is very common nowadays, especially in the rainy season. We are seeing a lot of patients with this classical stuck-on appearance, which we see. And some patients may have an anterior chamber reaction. Most of the condition we have to believe is the self-limiting. So most of the condition doesn't need any too much of treatment. And if at all possible, we can add lubricants, lot of lubricants and antibiotic. In case of limbitis, anterioritis, and endothelitis, you should start a steroid. And fluconazole is freely available, and you make use of fluconazole in case you feel it is a microspheroidal keratitis. Coming to pythium keratitis, it's a very rare condition, but it's a very severe condition. So here there is a tentacle-like projection in the ulcer, which is not some fungal ulcers which does not respond to normal antifungals. You have to think of this case. And the identification of zoospores is the gold standard. And the treatment is 0.2% topical linezolid or 1% azithromycin. So here I wanted to tell this patient a sustained injury with thorns and developed fungal ulcer. Patient had been treated with, the thorns were taken, most of them were taken, but patient was treated with antifungals, but patient did not improve. When we checked again, actually my retina colleague had seen this. So she referred to me. I saw a small foreign body was left behind. She had taken almost all the other parts, only one was remaining. And that was the reason for the ulcer not healing. So always think of a retained foreign body in case of an injury. Coming to viral ulcers, so herpes simplex virus can have a primary herpes and also secondary herpes. What happened is these herpes always have a latent infection, which the dormant virus will remain in the trigeminal ganglion. These are the various features that can occur. Reactivation can occur due to stress, sunlight, immunosuppression, any topical medications like prostaglandin analogs or a systemic steroid, any ocular procedures like LASIK or a cross-linking. So according to the head study, they have told that steroid should be used in case of stromal keratitis. And in case of stromal keratitis, there was no much benefit with starting an oral acyclovir. Whereas in an iridocyclitis, it is often prudent to start oral acyclovir. And a long-term prophylaxis study was also done with the heads too. And they found that acyclovir reduced recurrence risk by around 40%, which is a very, but it should be given for a long period, like 1 or 2 years minimum. That is acyclovir 400 milligram BD dosage, okay? Now coming to herpes zoster in keratitis. So this is, again, we will have a rashes affecting one part of the face. And it's always present as can affect cornea as pseudodendrites, nummular keratitis, disciform keratitis. Always you should have a history of herpes zoster or a herpes infection previously. The Z study has recently published as telling a long-term prophylaxis for valacyclovir in a low dose can be continued for 1 year for preventing recurrences. Coming to acanthamoeba keratitis, this is again, there are 2 types. Mostly it is epithelial pseudodendrites or ring infiltrates or a radial keratouveitis. So we have to do the scraping and culture to always come to a diagnosis. This is a simple case which came to us with a pterygium. he was asked to excise the tertium. He went to an Ayurvedic specialist and did some Ayurvedic treatment, after which he developed a yellowish infiltrate, which was a fungal infiltrate. And it was actually, we were giving the antifungals all topical medications and orally, but the patient, the ulcer was increasing. So what happened is, after this appearance, we started to give an azithromycin. That is, we try to treat the MGD along with it. And what happens is, we can see the ulcer started regressing. Thereafter, ulcer got into control. So what I wanted to say through this is that the ulcer is a vast topic, so we can't cover it within a very short time. But what I want to tell is, always check if the ulcer is not responding. Always check for the adnexa. Always check for a retained foreign body. And if not identified by you, please refer to a cornea specialist so that these can be picked up easily. Thank you.
Thank you, Dr. Nadhna, for that, for covering that intense topic in such